across developmental stages. And because we're getting started a little late, I'm just going to turn it right over to Dr. Anna Peretti and Dr. Greg Sturs.
All right. Good afternoon. So today we'll talk about pediatric psychosis across developmental stages. I'm Dr. Anna Peretti. I'm a child psychiatrist. I'll be tag teaming with Dr. Sturge, who is an emergency room physician, pediatric physician. So we'll start with talking about some presentations that we see come across in the ER. I will talk more about how do we identify and manage folks who come with symptoms suggestive of psychosis in the ER, and hopefully we'll close with talking about how we manage the patients that came across. So I'll hand it over to Dr. Sturge.
Thank you. So the patients that I selected are actually two real patients of mine that came into my pediatric emergency room. And I chose them specifically so that I would kind of demonstrate the breadth of the presentation of psychosis that we see in the pediatric population. So the first case is a 17-year-old male. He had no significant medical history, but he comes in under police custody. And he's really, the story I get from them that he's been agitated at home. He's had a real deterioration of function, that he's not able to go to school, that he's not taking care of himself like he used to. He's not bathing regularly and that sort of thing. The family who comes into the emergency room says that he's been using a vape pen to do THC, and they think that he's doing it almost daily. He is accusing the family of spying on him and is very distrustful of everyone. And there's no significant history of any medicines, no previous history of any psychiatric problems or anything else like that. It's actually kind of funny. This case is kind of funny because he was actually shooting me with laser beams from his eyeballs when I went to go see them. He was disheveled. His thought processes were disorganized, and he was operating in a world unto himself. The second case was a 14-year-old female. I chose this one because it's a little more insidious of a presentation. So she's 14. She has a long history of depression. The family had been dealing with this for many years. She'd been on several different medicines, and she's seen several different providers, including her primary care pediatrician. And then she finally made it to a psychiatrist who was adjusting things. Her presentation is that she's seen things. They recently had changed her medicine, and she didn't like the way it had made her feel. And so she had just kind of stopped cold turkey. Her mood had been worsening. She reported suicidal thoughts, but didn't have any specific plans. And she'd started seeing things over the past week or so. She described them as figures. They are peering at her, but they don't speak to her. They don't give her any commands or anything like that. So she has suicidal thoughts without intention or plan. And then she has these, she kind of thought that they were like almost like ghosts that she was seeing. And that she was seeing these things, and she had no other homicidal ideation. Her thought processes were pretty linear, and other than depression, her physical exam was pretty normal.
All right, thank you, Dr. Sturge. So we kind of have seen two cases that are presenting probably with symptoms suggestive of psychosis. So we'll talk about what psychosis is, what does it mean in a pediatric context, how do we evaluate psychosis in kids and adolescents, how do we assess for risk, and how do we manage and hopefully discharge them from the emergency room. So how common is psychosis? And even before we talk about the symptomatology, what is psychosis? Psychosis is actually a collection of symptoms. It affects our mind, and there seems to be some sense of loss of contact with reality. In kids, The commonest cause of psychosis typically is secondary to anxiety and depression, not primary. And we know that in kids, especially kids who are exposed to trauma, brief psychotic phenomena like hearing voices or seeing things can happen pretty frequently. So what are the symptoms of psychosis that we think about when someone says, hey, someone is suffering from psychosis? So the commonest symptoms that we look for are delusions, hallucinations, thought disorder, some disorganization of behavior, and in extreme cases, catatonia. Thankfully, in kids, catatonia is not that common. It's very, very rare. The commonest symptoms that we might find are delusions, hallucinations, and thought disorder with some behavioral disorganization that can be secondary. So when we talk about delusions, how do we define delusions? Delusions are false beliefs that are not accounted by someone's culture, religion, or circumstances. So they are beliefs that are false and that are not factual in nature. And sometimes we might find that with delusions, the whole delusion may not be false. There is some sense of reality in the delusion, but sometimes when we evaluate them, we look for whether the explanation of the delusion is realistic. So a lot of the times when people, especially the commonest example that people give is cheating by spouses. And this happens a lot of the times on the adults, where they talk about these issues and suspicions and paranoia about it. And sometimes we find that what actually they're suspicious of is real, but it's how they explain the idea of how they found these issues gives it the flavor of a delusion. Hallucinations are perceptual disturbances that are misperceived and that are not real and are perceived by that individual. One way to think about the differences between the hallucinations and delusions is hallucinations is a disorder of sensual misperceptions, whereas delusions and thought disorder are based on our thought process. Delusions are disorders of thought content, whereas thought disorder is a issue with organization and expression of thoughts. So when we talk about thought disorder, people are not able to communicate what they want to communicate, and we also are not able to understand what they are trying to communicate. So why is diagnosing and recognizing psychosis important? Because in children, hallucinations and delusions are pretty common. But the main diagnosis that we think about when we talk about psychosis is schizophrenia. The commonest age group of a typical onset of schizophrenia is between 14 and 35 years of age. Roughly 1/5 of adults who go on to develop schizophrenia or diagnosed with schizophrenia have developed symptoms before their 18th birthday. So if we can diagnose and evaluate and manage these folks, the morbidity can be decreased and the functionality can be maintained. So that's the importance of why we need to recognize psychosis early. And most of these folks who develop psychosis for the first time do present to the emergency room for the first time. They don't present to outpatient clinics. It's not that common. There is childhood onset schizophrenia when symptoms of schizophrenia start before age 13. It's rare, but it has extreme poor prognosis. So when we think about these symptoms, what do we consider developmentally normal or typical? The good news is that most children who exhibit psychotic symptoms or psychosis-like symptoms do not have a true psychotic disorder. So they do not truly have schizophrenia. Transient hallucinations are typically common in preschool children or even in adults, and they are benign. So the commonest hallucinations we talk about are hypnagogic and hypnopompic hallucinations. So hypnagogic hallucinations are hallucinations like you're seeing things or hearing things, especially when someone is trying to get to sleep. So it's in the twilight zone between full wakefulness and going to sleep. Hypnopompic hallucinations are hallucinations that happen even in healthier adults and children when people are trying to wake up from sleep. These are common, these are normal phenomena, and they tend to seem to occur more when people are stressed out. So we need to be able to differentiate this because these are temporary phenomena that go away. In kids, there is illogical thinking that happens that's pretty developmentally appropriate up until 6 and 7 years of age, because they have beliefs that things can happen that we're like, when we become adults, we are like, okay, that's not true. But that type of thinking is developmentally appropriate. It's when these illogical thinking or loosening of associations stay or happen at a later age, that's when we start to think it's abnormal. So let's say someone is presenting to the emergency room with symptoms that we think are suggestive of psychosis. So what do we do? So I think the first and foremost thing with any of these patients is we need to evaluate for safety, because folks with psychotic symptoms do have significant issues with suicidal ideation or thoughts and homicidal ideation. So we just have to be sure that safety is maintained, evaluated and maintained initially. And if there is a medical instability, we need to address that. We can try to de-escalate, but sometimes we may not be able to. At that point, we try to maintain safety and do the best evaluation we can while we look for options to treat. For safety, the key is having a quiet room with people that are calm and having enough people to support. That's very important. And giving the individual space so that they don't feel threatened or they don't feel like everyone is on top of them. Emergency medication can be used and should be used if necessary to help people decrease the distress that they are in. When we think about maintaining safety, one of the main things to look at is environmental modifications. So what are the things that we can do in the surroundings that can decrease the agitation and maintain safety? I won't truly go into management of agitation or aggression, as 2 weeks ago, Dr. Sood has talked at length about that. With environmental modifications, we need to decrease the stimulation if we can by decreasing the number of people in the room and having quiet areas that are calm, lights are dim, and not a lot of sensory input. If we can decrease the alarms or turn them off, alarms or monitors, that would be helpful. Giving the individual personal space and limiting transitions, like not a lot of individuals deal with that person in distress, rather having designated people only deal with that individual until the patient is safe. The key with maintaining safety and improving functionality in the emergency room is communication. We need to tap into the history from the caregiver, because they are our best resource in trying to understand what has happened to the individual in our care and how do we assess and go forward with evaluating and managing the condition. The key is to utilize one voice, which by mean very few individuals interacting, and keeping things consistent. It helps when we offer choices when they are appropriate. Just because someone is psychotic doesn't mean that they can't make choices. Obviously, there are folks who are so disorganized that they cannot make choices, but we need to try and offer choices and give them options to see if they are able to feel that they are in control in managing situations. And sometimes that itself can de-escalate an individual who is going through a psychotic episode. And practicing reflective listening. And a lot of the time when I evaluate someone who is disorganized or psychosis, is whatever they say, I try and reflect back to them and help them see that I'm trying to understand what they are saying. If we are just assuming what they are saying and going forward, we might be led down a path that might not end up the right way. And the important thing is to validate their feelings. If they are feeling distressed, angry, or paranoia, whichever. We try to validate. We don't uh, we don't join in with their psychotic symptoms, but we try to validate how they are feeling, and that gives them a sense of calmness to them, that people are trying to listen rather than people are trying to just evaluate and move on from them. So when we look at someone, let's say someone has come to the emergency room with symptoms that are suggestive of acute psychosis. So how do we evaluate? We talked about managing the environment, supporting the individual to be safe. We try to get as clear a history as we can to look at any organic causes of the psychotic symptom, because most of the time we need to rule out organic causes or medical causes before we think it's a primary psychosis. So we stabilize the airway and safety is maintained. The commonest things to look for are blood glucose and electrolytes, because dehydration can cause symptoms like this, especially someone who might have other psychiatric comorbidities already underlying. If there is if we can do a quick neurological examination to see if there are any focal neurological deficits. If there is a true focal deficit, then we may need to evaluate neurologically. If not, if we see that there are no focal neurological deficits, we try and evaluate based on the symptoms. We don't need to do the whole spectrum of lab work to figure out, but we go by the history. So here it's presenting as a lot of investigations to be done. We don't need to do all of them. We tailor the investigations based on the history we are getting and the suspicions that we have at that point in time. So like if there is a suggestion that someone has ingested some substances, toxicology screen is valid. If there is a 7-year-old kid and there is no history of any substance use or any ingestion of substances, probably that may not be needed. So we just have to tailor the investigations based on the symptoms and based on the history that we are getting. Of course, if there is in certain situations where there is no one to give any corroborative history, then probably we may have to go through the whole gamut. Things like autoimmune encephalitis, Wilson's disease, or urine porphyria, they can be done if there is a suspicion or if there is a history that is suggestive, but probably not needed in every case that we see. If we rule out most of the medical issues, then that's when we consider the symptoms to be suggestive of a primary psychiatric illness. So we just have to make sure that someone doesn't have a medical problem that might be masquerade or presenting as psychosis. So what are the common causes of psychotic symptoms in children and adolescents? So the big one is schizophrenia. It's the major psychotic disorder. Mood disorders do present with psychosis, with both bipolar disorder and depression, they do present with them. Autism spectrum disorders, the presence of psychosis is not common, but certain symptomatology within the autism spectrum, with folks with autism spectrum disorders, do present with symptomatology or behavior that do mimic psychosis. So we just have to be careful. Anxiety, especially when it is severe, does present with symptoms suggestive of psychosis or sometimes frank psychosis, especially with severe OCD. People who have been exposed to trauma and have been diagnosed with PTSD or trauma symptoms do present with psychotic symptoms that may be transitory. Substance use, both usage and withdrawal, can and will present with symptoms that are suggestive of psychosis. Sometimes medications, whether both usage or withdrawal, can present with symptoms that look like psychosis. So we just have to be careful in determining the cause, because if we can determine the cause of the psychotic symptoms, we may just need to treat the cause rather than actually treat the psychosis to decrease the psychotic symptoms. So when we talk about symptomatology, these are some of the few questions that we may need to think about. So what are the presenting symptoms? What is someone presenting with now? And how long have they been present? So what is the timeline of the presentation of symptoms and the severity? is there a family history of psychosis? Because if there is a family history of psychosis, these individuals who are presenting to the emergency room with psychotic symptoms have a higher risk of presenting with a primary psychotic disorder. Is the patient presenting with commanding auditory hallucinations? Because when someone presents with commanding auditory hallucinations, they are at a higher risk. They might need to be hospitalized because they are unstable and unpredictable. And if they are responding to the commanding auditory hallucinations, safety is at risk pretty high. So we just have to make sure that we need to ask that question, especially if someone is presenting with auditory hallucinations. But as the patient acted on these things, because that will give you an idea about safety and how they are managing or tolerating this symptomatology. And I think at the baseline, before the current presentation of symptoms, what is the patient's functionality? Because that will give you a clue into whether this has been an onset that's acute or insidious. Because sometimes, especially with schizophrenia, there is a long prodrome of functional deterioration before the emergence of symptoms, like hallucinations or delusions. So if we can track the level of functioning, that will give you a clue to see whether are we really dealing with schizophrenia or are we dealing with other psychiatric disorders that are presenting with a comorbidity of psychosis. So when we talk about hallucinations, we want to address it in a way that are easy for kids to understand. So when we are asking questions, we have to use wordings that are easier for the kid to understand. These are some of the things that we can ask. Has ever time you heard voices when you're alone? And what did you hear? Rather than do you hear voices, yes or no, and move on. So we just have to understand what are they saying. Sometimes I have patients say, yes, I hear voices, and come to find out they're actually hearing people talking about, because there are people next door, but they can't see. So we just have to be careful in evaluating these things and be clear in how we address it. So I won't go into detail with all of these questions. Delusions are very similar, especially with young kids. I typically will want to start talking about imagination and what do they understand about imagination. And talk, because there are certain perceptions that are misperceptions, but that are usual, because we all know about illusions, like when we are driving on the road and the sign is not fully done, or the sign that some parts of the lettering is gone, but our brain all tricks us into figuring out the full letters, even though all the letters are not present. So that's an illusion. So there are lots of those kind of misperceptions that can happen that are benign. So sometimes we just want to talk about imagination and whether the imagination played tricks with kids, because that might improve the rapport for them to tell us about what they are seeing or what they're hearing or what are their beliefs. And with older kids, sometimes you can ask about their beliefs and whether other people don't believe in what they're believing, and what are the differences and why do they believe in those things. And I think it was more about being curious rather than making a diagnosis. A lot of the time, the more curious we are in asking that next question, we tend to get more information about evaluating whether it's a true delusion or is it something within what we consider typical. When we are assessing delusions, we need to assess about paranoia, suspiciousness, and how often is it real or how often is it not real. So when we talk about psychosis, we are talking about primary psychosis, which is schizophrenia, and secondary psychosis, which can be secondary to either medical causes or other psychiatric disorders. So how do we differentiate them? Sometimes age of onset can differentiate. Typically with primary psychosis like schizophrenia or schizoaffective disorder, it starts around early adolescence, typically around 13, 14 years or young adulthood. With secondary psychosis, it can occur at any time. Typically, when we take a longitudinal history of primary psychosis, the start tends to be insidious with a decrease in functionality long before the symptoms of what we consider positive symptoms of psychosis, which are hallucinations and delusions. and disorganizational thought present. So there is a decrease in functionality probably at school, at home, or both places. And that will give you an idea whether we are dealing with someone who may be going into the throes of schizophrenia or at a high risk versus someone who has other psychiatric disorders or medical disorders that are presenting with psychosis. When we think of hallucinations in primary psychosis, predominantly the commonest one is auditory. If we are we are talking about visual hallucinations, we are mostly looking at either it's a secondary psychosis or it's secondary to a medical condition. With auditory hallucinations in primary psychosis, there's significant loss of insight. With secondary psychosis, typically we see that there is some insight, but at times, if the symptoms are severe enough, loss of insight will be there. Delusions, when they are present in primary psychosis, they are typically paranoid, complex, and bizarre. With secondary psychosis, they may be most of the times it's non-bizarre, but at times they can be. Sometimes it is mood congruent with their mood. The delusions can be congruent with their mood, and sometimes it can be non-congruent, but most of the time it's very congruent with their mood. So with someone with depression, we might be talking about nihilistic delusions or negative delusions that are negative in nature and derogatory in nature to them. Additional physical findings are typically not present in primary psychosis, while they may be present in secondary psychosis. Labs results typically are normal in primary psychosis. When we think of premorbid functioning, typically, especially with schizophrenia, we might see premorbid functioning to be impaired. And that gives us the clue that, okay, this is a disease process that has been going on before for a while. And there seem to be some family history of psychiatric disorders, especially in schizophrenia. When we think of the course of psychosis, with primary psychosis, typically the course will be remitting and relapsing. So they present episodically with worsening symptoms. With secondary psychosis, as long as the primary disorder is treated well, the psychosis tends to resolve. So what are the challenges in diagnosing someone with psychosis, especially in the pediatric population? The difficulty is especially with young kids, they have vivid imaginations and they have magical thinking. So when we think of magical thinking, it's like, so a kid says, if I think about something bad will happen. So 5-year-olds, 6-year-olds can have those thoughts, or they might say, I need to touch this for the good things to happen to me. And sometimes we all have certain level of magical thinking. Sometimes we call them superstitions, right? Some religious beliefs, rituals that we all do. Those are all magical thinking because there is no logical explanation of why it happens, but we all believe that. Typically, these things tend to decrease by around age 10. And if these persist, then and they become severe, then we need to start thinking about folks who are going to develop primary psychosis. Especially with schizophrenia, there seems to be a link that's not fully proven yet, that people seem to think that if there is a high level of magical thinking beyond age 10, the risk of psychosis is high. And with folks with developmental disabilities like autism spectrum disorder or other developmental disabilities, it's extremely challenging to differentiate because these are folks who are developmentally much younger than their physical age. So their thought processes will be different. So it's significantly harder to figure out whether are we dealing with some psychotic symptoms or is it still typical to them. If we talk about early onset schizophrenia, in childhood and adolescence, we talk about childhood schizophrenia, which is the schizophrenic symptoms start before the age of 13. It's rare, but it has extreme poor prognosis. Early onset schizophrenia is schizophrenic symptoms of schizophrenia starting from 14 to 18 years of age. Male tends to present much earlier than females by 5 years. When symptoms present, the positive symptoms tends to be predominant. So hallucinations, disordered thought processes, affective flattening, and hallucinations, these seem to be more common in early onset schizophrenia. Complex delusions and catatonia are infrequent. So when delusions are present, they are going to be very simple, mostly paranoid delusions that will impact their functioning. And if we get a good history, there is a prodrome of declining functioning with social isolation, school difficulties, isolation at home, and significant issues with grooming and activities of daily living. Most of these patients who go on to develop schizophrenia do present to the ED in an active phase of illness where they are actively psychotic with florid hallucinations and delusions with disorganized thought process. How do folks with mood disorder and psychotic symptoms present? It's not common for young people to present with negative symptoms of schizophrenia, but if they do present, they can be misdiagnosed as depression. So in that scenario, we tend to look at more of symptoms that are much more functional impairment and the prodrome that we are looking for. Because if you won't be depressed for 5 years with decreased functionality, you might be presenting much earlier than that. Mania, especially in teenagers, if they're present, can sometimes present with florid psychosis. So we have to be aware. And with these folks, a lot of the time, the delusions or the hallucinations tend to be mood congruent. Major depressive disorder can present with psychosis, sometimes with mood congruent or incongruent delusions and hallucinations. But the mood issues predate the development of psychotic symptoms, especially if someone who has a history of mood disorder. So when we think of psychosis, how do we differentiate? So when we think of timeline of the symptoms, if it is an acute symptom, acute presentation, probably we need to rule out organic illness first. If there is a acute with waxing and waning course, we might also need to rule out delirium because that can present with psychotic symptoms. If the timeline of symptoms is chronic with the prodromal illness of decreased functionality and then psychotic symptoms presenting, then we are looking at psychiatric illness, either primary with schizophrenia or secondary with other psychiatric illness like mood disorders or anxiety disorders. With the age of the patients, especially in our population, if we are looking for someone who is a young adult or an adolescent, probably psychiatric illness need to be ruled out because that's the common age where we are looking for the initial presentation of schizophrenia. And we also look at family history. If there's a family history of medical illnesses or neurological illnesses associated with psychosis, probably that's what we need to rule out first before we think it's a schizophrenia. So how do some of the common psychiatric disorders that are prevalent in this age population, how can they mimic psychosis? Because especially with autism or pervasive developmental disorders, some of the folks who have severe autism and functionality, they do present with perseveration of thoughts. So they are repetitive, they can talk about the same thing over and over again, or go into tangents about their thoughts or things like that. So, and they have social skill deficits. So that's how we differentiate. We try and differentiate psychosis, because if these symptoms, if these thought processes are there predating the presentation to the emergency room, sometimes it might be that there is a functional deterioration, but there are no true psychotic symptoms that are present. With ADHD, especially with severe ADHD that's not treated, there might be some behavioral disorganization, but typically you may not see florid psychotic symptoms in these folks. They might present with disorganized behavior, some impulse control issues, and hyperactivity that might mimic psychosis. In these folks, if we treat the ADHD well, these symptoms disappear. With OCD, especially folks who have OCD that's been chronic and severe, that's not well treated or well managed with medication and therapy, they are prone to severe obsessive thinking and compulsions. And a lot of the times, the severe obsessive thinking becomes delusional in nature. the explanations of their obsessions and compulsions get into the territory of delusional thinking, and that might mimic psychosis. Folks with severe anxiety disorders, especially when there is extreme anxiety and situational anxiety, their brains are tricked into perceiving things and misrepresenting things based on the fears that they have, and that might present as anxiety as psychotic phenomena. In PTSD, the trauma itself can cause nightmares and traumatic hallucinations. With mood disorders, if you see folks with mania, they can present with perceptual abnormalities. In kids, especially mood disorders, especially depression, can present with irritability as the primary symptom. So in those folks, you may still see some perceptual abnormalities. But if you treat the mood issue, these perceptual abnormalities will go away. So with autism, because this is difficult to evaluate at the best of times, the good news is the co-occurrence is relatively rare. The symptoms are very difficult to differentiate. The other challenge with autism, especially folks who are either nonverbal or folks who have minimal communication abilities, they do have some anomalous perceptual experiences, and they do suffer and struggle with a lot of sensory challenges, and that can be misperceived as psychotic symptoms. And they also have cognitive rigidity and concrete thinking that can seem like psychosis. So how do we try and differentiate? With folks with autism, we find that at times they have difficulty understanding the rules of common social communication. So when they talk about things, they don't have an understanding of when to stop or when to start engaging other people in a conversation. So they can present with disorganized thoughts, but in their head, they are able to link through things. A lot of the time, we have to rely on the caregivers to give us an idea of whether that's usual or that's something that's new in what they're perceiving. In psychosis, it's more of an aberrant interpretation of others' mental states. So they have these stimuli that are internal stimuli, and they are given explanation that's bizarre. In autism, there is an impairment of theory of mind. Theory of mind is a concept that typically it's a state of mind that develops by age 5 for folks. Typically, it's that people can have perspective taking, so they can see that other people can have a different perspective, even though they're all seeing the same thing. For folks with autism, it might develop later or not at all. So there is a spectrum of theory of mind that happens. So it's not like whether it's present or not. So some folks who are highly functional on the autism spectrum can have mild impairments of theory of mind, so they can function relatively well. They can understand what other people are thinking, but they may not express or communicate appropriately in real time about what other people's feelings are and how they are perceiving things. In psychosis, there is a big tendency for external attributions of their symptoms. So when they're hearing things or seeing things, there is an external bias about why this is happening to them. And in psychosis, especially, there is a hostility bias where, especially with paranoia, it's something being done to them, and they don't have any control over it. With folks, especially in the autism world, who are whether nonverbal, minimally verbal, or poor communicators, there's a significant difficulty in distinguishing between reality and their perceptions. And if we throw the sensory disturbances into the mix, it's really, really hard to differentiate. So we tend to focus more on functional impairment and manage the functional impairment with the hope that the symptoms resolve. So I won't go into the whole list. So this is a generic list of substances and medications that can cause symptoms suggestive of psychosis because of either intoxication or withdrawal. In kids, the commonest substances that we see are alcohol and cannabis. These are the two main substances, whether intoxication or withdrawal do present commonly with psychosis. But all of these can precipitate psychotic illness. With substance use, it's interesting because there is a significant comorbidity in folks who can have both primary psychotic disorder and substance misuse. Alcohol, as I said, alcohol and cannabis are the most common substances that are linked. Then there is a bidirectional impact on the disease course and outcomes, which means that someone can develop a primary psychosis and then go on to use substances to relieve the distress, or someone can start using substances and then develop psychotic symptoms. Typically, when we think about this comorbidity, there are four main ways that we see people developing symptoms. So someone can have a primary diagnosis of psychosis and then start using substances which will exacerbate the symptoms. Someone who are just using substances and then they start developing symptoms suggestive of psychosis, which is a manifestation of substance use. And this pathway has a brief course and has the best prognosis of all the pathways. The most common one is concurrent presence of substance misuse and psychosis, and they are feeding off each other. And these are difficult to treat and manage in the long term. Or someone starts using substances, they develop psychosis, and then it either increases the risk of substance misuse or alters the course. So these are all the four main pathways in which the comorbidities between primary psychotic disorder and substance use occur. But if we are seeing psychosis secondary to substance misuse, that's the best outcome. We can easily treat it, manage it, and that has a pretty good prognosis. With anxiety disorders, the flavor of presentation is typically presents a significant history of anxiety, either treated or untreated. If the anxiety is very severe, it can border on paranoia and disorganized thinking, because a lot of these folks tend to start avoiding things and they have to make up ways of thought processes or reasons why they need to avoid something. So it can get into the point of significant avoidance and paranoia. Typically in these folks, if we treat the anxiety, it resolves the psychosis. However, as I said before, in severe OCD, the symptoms of OCD are so severe, the explanation of why they need to do the compulsive behaviors can be delusional in nature. Initially, the compulsions may start off as an undoing of the obsession. So they have to do a certain task 3 or 4 times. Otherwise, something bad will happen. So that might start off as that, but it can change to why that something bad has to happen. And then with time, typically in folks whose OCD can get severe, you start to hear more of that delusional thought processes and illogical explanations of why they have to keep doing those compulsions. So when you think of how do we differentiate between OCD and schizophrenia? With OCD, there is a history of anxiety, then you start developing the obsessions or compulsions. In schizophrenia, you don't see any of that. In OCD, typically perceptions are real, perceptions are intact. In schizophrenia, you start to see hallucinatory phenomena more commonly. In OCD, if we probe deeply, they can at times they can understand that their obsessional thoughts are their own, but they are severe and they cause distress. For folks with schizophrenia, especially with this perception of thoughts and perceptual disturbances, they start to believe that those are real, and it's hard for them to say that, okay, I know that they are not real. So the reality testing is different. And especially early onset OCD and early symptomatology, most of the folks do have awareness that their obsessions are unreasonable, but they can't help it. In schizophrenia, the disorganized thoughts and behaviors, there is no awareness of that they're unreasonable. With OCD, unless there is a delusional component inside, is pretty reasonable. They are able to understand what is happening to them. With schizophrenia, reality testing is impaired, and sometimes cognition is impaired as well. I'll briefly touch on delirium because that can be one of the commons in presentations to the emergency room. With psychosis, there is a awareness of time, date, and place, but it may be in delirium, it is not there. Attention seems to be unaffected in psychosis, even with folks who are responding to external stimuli. They do seem to attend to other things as well. Memory is retained in psychosis, whereas memory for recent events in delirium is not there. Calculations are interesting because in delirium, folks are even unable to do simple calculations that they know before. In psychosis, unless the functionality has decreased so much that they cannot function at all, the ability to calculate is retained. So hallucinations in delirium, because it's being organic, typically is more visual or tactile. In psychosis, especially with schizophrenia, it's mostly auditory. And in delirium, we have to rule out substance use. In psychosis, or especially with a primary psychiatric disorder, substances are not really involved. So let's say we diagnose someone with psychosis in the emergency room. So how do we manage? Because the whole idea is to how do we manage them, treat them well, and then hopefully send them home with further follow-up. So the key is calm environment and safety. And if we need to use medication, medication should be tailored to the primary cause rather than treat the symptoms. Seclusion and restraint can be used, but use only if appropriate and use for limited times because that might itself cause a lot more distress. Benzodiazepines can be used to help with anxiety, but we have to be careful if we suspect delirium. If we are seeing florid psychotic phenomena with hallucinations, antipsychotics can help manage both the distress but also decrease the risk. So when we think of antipsychotic options, the commonest things we can use are olanzapine, risperidone, chlorpromazine, and haloperidol. Those are the common. Quetiapine is sometimes used, but these are the common things that are used. A lot of them come as both oral and IM. That helps. So when we look at the medications, I won't go through all of this. I think the key is with with kids, the goal is to start at a lower dose. The commonest things that I see being used in the emergency room are typically risperidone, olanzapine, or haloperidol. Those are the common things that are used. With haloperidol, it's about 0.025 milligrams per kilogram body weight. The thing is, it still takes a while for the medication to start. It lasts for 3 to 8 hours. The max typically used is about 5 milligrams. I got this chart from Children's Hospital of Philadelphia. It's in their guidelines on how to use medications. With olanzapine is interesting because olanzapine can be used on its own. You don't need a benzodiazepine to calm someone down because it's extremely sedating. Typically, if the body weight is between 30 to 60 kilograms, you can go with a 5 milligram pill. If it is more than, if an individual weighs more than 60 kilograms, we use 10 milligrams. Risperidone, if it is below 30 kilograms, 0.25 milligrams is the dose that's reasonable. If it is more than 30 kilograms, probably 0.5 milligrams. These both olanzapine and risperidone come in tablets that are dispersible, so it's easier to administer and tend to calm people down faster. But always think about QT prolongation or agitation. Sometimes, especially with kids, there are instances where there is a paradoxical reaction even to antipsychotics. So if you start to see folks being agitated on antipsychotics, we may have to be more careful. So when do we hospitalize these folks? So if we have used medication in the emergency room, but they're still acute, safety is a major concern, especially with suicidal or homicidal ideation, and the symptoms are not resolving at all. And the functionality is so impaired that these folks can be sent home with a reasonable plan because they won't function in the community. If there are command hallucinations, the risk is extremely high, and these folks need to be hospitalized for any length of time to make sure that they are safe before they can be discharged back into the community. So let's say folks are safe. Uh, we evaluated and treated them in the emergency room and the psychotic symptoms have resolved, then they can be safely sent home. Sometimes if there are folks who have a diagnosis of schizophrenia, but they have missed their medication, they have chronic psychotic symptoms, but they have adequate support services and the symptoms are not worsening. So we can stabilize them on medication and send them back home with follow-up. However, if this is the first episode of psychosis that is presenting for the first time, we may need to refer these folks to the early intervention in psychosis teams. There are about 9 teams around the state that do take in folks as young as 14, and they follow them up for about 2 years, especially folks who have a higher risk of psychosis. It could be schizophrenia, it could be secondary to something else, to other psychiatric disorder as well. If they have a higher risk of psychosis, they can provide supportive services and get them hooked up in the community. So most of them operate through the auspices of the local community service boards. Um, uh, so refer to them, and most of them get services for at least a minimum of 2 years. So they're followed up to see if they go on to develop schizophrenia or not. And a lot of these services, these teams follow these folks, can follow these folks up until the age of 25. So there's a long follow-up that can happen. And they not only connect them up with folks who are in need of medication, therapy, but also social supports, group therapy services, school supports. So they can provide an umbrella of services for these folks who are at high risk of going on to develop schizophrenia. I'll turn it over to Dr. Sturz to talk about the cases.
Yeah, so with the first case, the 17-year-old who was pretty disorganized. He, like I said, he was disheveled, disorganized speech. He was responding to clearly internal stimuli and had some paranoia. He got a UDS that was positive for THC, and his labs were pretty unremarkable. I am of the opinion that every new onset schizophrenia gets basic lab work in the emergency room. We talked about that long list of workup for this, and that's often impossible to do in the emergency room. But I did include a CRP on him, and his was 0. He did get he was pretty agitated and got IM haloperidol, and then we pretty quickly started him on some risperidone. He was in the emergency room for 2 or 3 days waiting on placement, and his agitation definitely improved, and his positive psychotic symptoms definitely seemed to lessen while he was there. The presumptive diagnosis for him was THC-induced psychosis. He ended up getting admitted and did pretty well. I saw him one other time, and he had much milder symptoms, and then he aged out of my system. So I lost track of him after that. But it's difficult for us to say in the emergency room, is this exclusively related to the cannabis? Especially, I'm seeing a lot more of the cannabinoid and synthetic cannabinoid related psychosis in the emergency room than we used to with the high THC products and the synthetic cannabinoids. Or is this just his first episode of psychosis, and he'll go on to with schizophrenia or something more sinister? So he did okay as far as the emergency room goes, but ended up coming back and needing additional care at some point. Yeah, so stepping back, so the girl that I talked about, her she had no focal neurologic changes. Her screening labs were very normal. She had very involved parents, and they were able to contract for safety. Her visual hallucinations did make her anxious, but they were able to get follow-up with their psychiatrist within 24 hours. And I don't believe she ended up needing to be admitted. I believe we turned it back over to her primary psychiatrist, who was able to get her in the next day. I do believe both of these patients were referred to the community service board for that psychosis comprehensive treatment program that we were talking about.
Right. Thank you. I think, Kim, it's you.
All right, so I am not going to belabor this. We are at 1 o'clock. So if you are not familiar with the VMAP program, we offer provider education. This series is a part of that. We also have the VMAP line where you can call Monday through Friday between 9 and 5 and speak to a clinical and adolescent psychiatrist, a care navigator, and or a licensed mental health professional. We do not have 24-hour access. However, you can leave a message and someone will give you a call back the next business day or later on that day if you do need us. You can go to the next slide. You can skip past this one. I just said that. And finally, this is a map of where we have hubs in the state. So we do cover the entire state. This is significant because if you are in the far Southwest, you may have different resources available to you than someone that's in Northern Virginia. So you will be able to speak to someone that is in your area. Unless you are calling for our early childhood 0 to 5, all of those calls are fielded out of our Carilion partnership out in Roanoke. The final thing that I want to say is in the chat, I did place a link to a Survey Monkey. Please complete that survey so that you can receive your CME credits. The CME credits come directly from VCU, but you do need to complete that survey before that can happen. Are there any other questions for the experts? Since you have them here, they're happy to answer questions if you have any. There were no questions in the chat. There was a couple of comments, but no questions. Please complete the survey. You have received surveys for the other 2 webinars if you participated in them, as well as a general survey that we want to use to help us evaluate if we should continue with the ED series, if this is something that you all found useful. So please check your email, please complete your surveys. If you did not receive a survey, you can email me. klewis@msv.org is the way to reach me, and I will be happy to get that to you. Thank you so much for your attendance. And Dr. Sturs or Anna Peretti, did you have any final thoughts?
Yeah, I think, thank you all for attending. Hopefully this was useful.
All right, well, thank you so much. And you guys enjoy the rest of your day.